Welcome to this version of Inside the Wellness Dentistry Network. Tonight we're going to talk about, in our concept clarification segment, staging and grading in the new periodontal disease classification system. We're also going to look at two cases that are going to be discussed during the staging and grading exercise. The how you say it is so important segment is also going to deal with staging and grading and how it simplifies our language. And even moving beyond the mouth is going to talk about how does staging and grading help us, help to move us closer to understanding the systemic impact of periodontal disease. I want to remind everybody that in our Wellness Dentistry Network library, there's a table of contents. So if you have hygiene teams, if you have assistants, if you need help going back and reviewing or trying to find out what was covered in some of the earlier webinars, you have this table of contents. So again, we've covered a lot of things and we'll continue to build on this as we grow in these monthly sessions. So periodontal case typing is what we used to do. And what I wanted to do is just review this a little bit. It's really easy, but we had these charts that we would hang up in our operatories, and we talked about types of disease. Now, these charts and this assessment was done from collecting clinical data and then looking at the chart and seeing what column fit the clinical data that we obtained looking at our patients. What case typing did for us is it identified the disease severity. It basically looked at the disease severity. However, it did nothing to tell us about the rate of progression of disease. It also had a definition of what healthy dentition was, where the new staging and grading doesn't have that. So if you have a healthy patient, 2 to 3 millimeter pockets, zero bone loss, zero bleeding, you're just going to call that patient healthy and stable. The other thing is the disease classification and the case typing suggested a particular recare frequency. Our staging and grading still does that. However, the case typing did not take risk modifiers into account, or staging and grading does that. And staging and grading, what it really does, it expands our ability to add more dimension in our description of the disease. And I hope that becomes clear over this next hour. So in case typing, what we did is we basically collected clinical data. We looked at probing depth, and we looked at the gingival margin, which describes recession, and we got clinical attachment loss. We took that clinical attachment loss number, we went over to the chart, we found the appropriate column, and we created a case type. And so we always use the word generalized or localized. We're still going to do that with staging and grading. Disease activity or stability was determined by bleeding on probing. And again, we would have a case type. So this was what we used to do, and I left the case typing exercise in the library, and I left the case typing chart in the library, but I've added new additional materials so you could have your option of either staying with case typing if that's what you do, or if you're just getting new to it, you could start there and then you can move on to staging and grading. So a little bit about staging and grading. In the video section, video 15 in the video section under section 2, which is gum disease, there's a small 5-minute video about the World Workshop that was put together that produced this staging and grading criteria. And that World Workshop was basically the American Academy of Periodontology plus the European Federation of Periodontology, and they got together and they created this new document. Now, I'll tell you, when I look at the table of contents, this workshop was broken into 4 work groups. And the first work group looked at periodontal health and gingival diseases and conditions. The second work group looked at periodontitis, and they wrote all these different articles. It's a very, very comprehensive, robust group of articles about, again, periodontal health, plaque-induced conditions, non-plaque-induced conditions, classification of disease, age-dependent distribution, staging and grading. I mean, it goes on and on. Work group 3 looked at periodontal manifestations of systemic diseases and developmental and acquired conditions. Work group 4 looked at peri-implant diseases and conditions. Again, 313 pages of information in this workshop, and what came out of it are our staging and grading charts. So there was a lot of thought and a lot of effort that went into using these, and this is the way not only the world's moving, but that we want to move in our practices. So this explanation, I hope, will really help you understand this, this what seems to be somewhat complex, but I hope I can simplify it for you. So when we look at staging, this is the very first thing we're going to do when we have a diseased patient, is we want to stage the disease. And this staging is used, and the term staging is used because it reminds us of oncology. When we have a cancer, they'll stage the cancer. The consumers are used to, or patients are used to hearing this language. And what it talks about is the severity. But if you'll see, there's three main pieces to staging. It's how severe is it, how complex is it, and how distributed is it. This is what really controls, or what we're trying to decide from the stage. It's severity, complexity, and the extent and distribution. And I'll talk about how we do that, because we're going to use clinical attachment loss like we did before. We're going to use radiographic bone loss like we did before. We've now added a tooth loss capability to this severity of the disease. And then the complexity of the disease is going to be determined by our probing charts. And if there's anything complex in our probing charts, and our extent and distribution is going to look at our 30% of the teeth involved, are more than 30% involved, or less than 30% involved. And that's what's going to determine our localized or generalized. In grading, grading is going to be related specifically to the rate of the progression of the disease. In other words, is it happening fast? Is it happening slowly? And do I have direct evidence to tell me how fast it's going? Is there been no bone loss over 5 years? Is there less than 2 millimeters over 5 years? Is there greater than 2 over 5 years? Do I have direct evidence? If I don't have sequential radiographs, then what would I use indirectly? Well, I could look at how much bones lost divided by the age, and I get a ratio. And if it's over 1, it's severe. If it's less than that, then it's going to be a lower grade. Or what about biofilm deposits? What about people with heavy biofilm deposit that has almost no destruction? That might be a slowly progressing disease. We're going to assume most people are going to be grade B, which is going to be destruction commensurate with biofilm deposits. And then you might have some people that really don't show much biofilm on the teeth, but they really break down quickly. These are grade C patients. So everybody gets a grade A, B, or C. But the interesting thing is, as a clinician, we should initially assume grade B and seek specific evidence to prove otherwise, either grade A or grade C. So grading is really just like in school. You get an A, B, or C. It's the same thing with grading, and it has to do with rate of progression. And interestingly now, some modifiers are coming into effect. And some of the modifiers are coming to effect, and the two big things that modify this disease are going to be smoking, no smoking, less than 10 cigarettes a day or greater than 10 cigarettes a day. That's going to change our grade. And our diabetic patients that have poor glycemic control, that's going to also advance our grade. And what's going to slow our grade down is if you're diabetic and you have normal glycemic control, or you have no diabetes. Grade B are going to be our controlled diabetics. So I'm going to have quite a few examples, or quite more discussion on this. So I just wanted you to get familiar with the charts before we moved into the exercise. So here's the summary. A patient comes in, they have disease. We're going to establish a stage. It's going to be stage 1 through 4. What are we going to use to do that? Our radiographs. It's going to tell us severity. Our periodontal chart, that's going to give us complexity. And our clinical presentation. Clinical presentation is going to give us the extent of distribution and some other things that we can see with our eyes. And then our grade A, B, and C. We're going to base it on radiographic bone loss. We're going to base it on the percent of bone loss divided by their age. We're going to take into consideration, do they smoke? How about the metrics of diabetes? Their ability to control biofilm is going to help establish that grade. And then are there medical risk factors and other inflammatory conditions that we could use to determine if this disease is starting to affect systemic health, or if the systemic health is affecting this disease expression? So again, the other thing the grade will help us determine is how well will they respond to therapy. If you have somebody that's slowly breaking down, they might respond really well. They might not respond really well if they're grade C. And we know smoking really influences that, and so does diabetic management. We also will be able to look at potential systemic health influence and biomarkers in our grading. So let's get right into it with our first patient. And what I would like to tell you here is he's a 60-year-old. And so when we look at the radiographs, we want to look at the interproximal bone levels. We know the bone levels should be no more than 2 millimeters beyond the cemento-enamel junction. And what we're trying to do when we look at a set of x-rays is just predict if we see any bone loss or not, and just give a prediction. We want to look and see, is the bone loss horizontal or vertical? What's the pattern of bone loss? We want to see if we can see any suggested furcation involvements, radiographic furcation involvements, any ridge defects, or missing teeth. These are things that we can obviously see off radiographs. So as we take a closer look at these radiographs, and the best radiographs that we can use are going to be our bite wing radiographs, because they're taken at a more horizontal impression. But we're going to look at these radiographs, and what I tried to do in the red circles is outline areas where there's clearly some bone loss. And so you can see that there's clearly some bone loss. And we know that, again, this bone should be 2 millimeters below or more below the cemento-enamel junction, and the bone pattern should also be parallel to the two DEJs, the dental enamel junction. And so if you start to get bone patterns that are going in a different direction than the line between the two DEJs, then you know you have some bone loss. And then you want to ask, is the bone loss horizontal or vertical? And so I tried to demonstrate here that we have some horizontal bone loss. But these green circles represent that I don't have furcation involvements. I don't really see any furcation involvements suggested on the radiographs. I don't see any ridge defects, and I don't see any missing teeth. So again, what we have here looking at the radiographs is just make some prediction about the percent of bone loss that's visual on the radiographs. So here's the summary of this particular case to help us determine the first part of our staging, which is severity. I would say there's somewhere between 0 and 20%. If you want to say 15%, if you want to say 25%, I get that. This is subjective. This is slightly subjective, which you'll get a feel after you do more and more of these. I don't see any vertical bony defects. I don't see any ridge defects, no furcation involvements, no missing teeth. And of course, we're always looking for other pathology on the radiographs. I don't see that. So we would use this data and we would say, so far, what stage is going to be best for him? Well, let's go to our chart, and we're going to look at where 20% would fall in the stage chart. And we're using radiographic bone loss to determine that. That's what RBL stands for. And again, it's stage 2. It's about the coronal third. Now what we want to do is say, how complex is this disease? How complex is this disease, and what are we going to use? We're going to use our probing depths. And you'll see that in stage 1 disease, the maximum probing depth is only 4. In stage 2 disease, the maximum probing depth is 5. And in stage 3 disease, the maximum probing depth is 6. And you'll see some other qualifiers for the stage as well. All this is mostly horizontal until we get to stage 3. We can start to have some vertical bone loss, and we can start to have some furcation involvements, class 2 or 3 in stage 3 disease. So let's look at the complexity by looking more closely at the periodontal chart. And what are we going to use off the periodontal chart? We want to use probing depth, clinical attachment loss, which is going to be the addition of the probing depth and the recession. And then, of course, we're going to look for furcations, and we're going to look for other things due to periodontal disease, which would be, if you have, this disease is going to be very complex. If you have bite collapse, drifting or flaring teeth due to perio. And so based on the periodontal charting data, in addition to the radiographic data, does the complexity of the disease change or advance the stage? Remember, we're at stage 2 right now. So does the complexity change it? And let's take a little closer look. So here's his periodontal charting summary to determine the complexity. And in the pocket depth data, there's 2 pockets that are 6 or more. Well, that automatically pushes us into stage 3, but there's 8 that are 5 millimeters. That would be stage 2. So there's a generalized recession pattern across this case, more than 8 teeth. And there's some localized attachment loss at 6 millimeters. There's 9 spots that are 5 millimeters, but it's mostly generalized in 3 to 4 millimeters. There's some class 1 furcations, but not 2 or 3. There's no mobility, no lost teeth, but there's 48 sites of line bleeding on probing. So we know this disease is active, and we know this disease is generally active, meaning it's a generalized disease pattern. So let's go back to our staging chart and now look in the complexity column. And we know from our radiographic interpretation that we were stage 2, but now this gets a little bit more complicated because in the complexity section, we have 3 to 4 millimeters of clinical attachment loss. We have some isolated spots of more than 5 millimeters of clinical attachment loss. These are our top 2 circles. And then in the bottom 2 circles, we have our maximum probing depth is 5. We have a lot of those, 9 of those, but we have some that are greater than 6. So really what we have is we have a mixed infection where we have criteria from both stages represented in this infection. And again, I wanted to remind you that it's the pocket depth that makes the complexity what it is, that gives you a stage. And so it's really, really easy to look at your radiographs, look at your perio chart, and just look on the perio chart and say, do I have any 4, 5, or 6 millimeter pockets? And if I do, it's gonna help me determine the increased stage or what stage we should be in based on the disease complexity. And that's the perio chart. Stage 4 gets very complex because these are cases that need to be rehabilitated. These are cases that have secondary occlusal trauma, which is trauma or mobility in the presence of a reduced periodontium. So this would be already breaking down. Severe ridge defects, and when you have bite collapse and that kind of thing. This is what's going to determine stage 4. But our pocket depth 6 or greater is only going to still keep us in stage 3 if we don't have any of those stage 4 criteria. So far, now we want to look at the clinical presentation. What do the teeth look like? What does the biofilm load look like on the teeth? And I can tell you at disease identification, you can't see this disease. We had to probe for it. And so I want to look at the clinical presentation and ask myself these questions. We've already looked at the severity of the radiographs. We've already looked at the complexity, which is determined by the perio chart, probing depth. Now we want to look at the extent of distribution of the disease and start to make some other notable observations. I don't see bite collapse. I don't see drifting or flaring. I don't think this mouth needs to be rehabilitated because of periodontal disease. There's definitely more than 20 teeth remaining. This is not localized juvenile periodontitis where we get that molar incisor pattern. This is very severe. And biofilm management is good. There's good biofilm management on this case. I don't see much on the teeth at all. And so what we have to decide is now we have to give this disease an extent classification by is it localized or generalized. And when you look at localized or generalized, we're talking about 30% of the teeth or more. And so here's what we find. Localized is less than 30% of the teeth. Now, if most of our patients have 28 teeth or some number like that, and you multiply that times 30%, that's going to be about 8.4 teeth. So it's going to be 8 or 9 teeth that's going to drive the localized and the generalized words. And so we're going to use those, but we're going to call it more than 8 teeth. If it's more than 8 teeth, we're going to say generalized. If it's less than 8, we're going to call it localized. So as I summarize where we are on staging, based on the clinical presentation, the data that we know so far, in addition to the periodontal chart and the radiographic data that we already went over, does the complexity change and advance the stage based on these questions? And I don't really think it does. So again, here's what we have as we look at the extent of distribution. We have a generalized condition on our stage 2 criteria, and we have some localized greater than 5 millimeter pockets and a couple or greater than 5 millimeters of clinical attachment loss and a couple pockets greater than 6. That's going to drive us to stage 3, but it's going to be very localized. So here's where this is going to go. We're going to have some stage 3, some stage 2, but localized stage 3, generalized stage 2. Now let's grade it. As we grade it, we're again looking at biofilm in the biofilm assessment. The clinical presentation, as I reminded you just now, is there's not a lot of biofilm on the teeth. And then how about the response to therapy? What are the things on the medical history that could tell me how he might respond to therapy? And the 2 main factors are smoking and diabetes. And then as we get more sophisticated into this, we're going to think about systemic biomarkers that could give us hints or indications about how this disease is affecting the systemic inflammatory component. That's going to be HSCRP. And we're using other biomarkers in Europe and other parts of the world called MMP8. We don't have that yet in the United States, but we will have this, I'm sure, someday. Remember, on grading, we assume grade B unless the evidence proves otherwise. So based on the rate of bone loss and the biofilm levels, do we have any, or can we provide direct evidence to move from grade B? I'm not sure that we can. Let's look a little bit closer. So in the rate of progression, we need direct evidence. We need direct radiographic evidence. And we'll talk about that as we go along a little bit further, because I'll show you what I have on this patient. We also want to look at the biofilm, and we've already suggested that there's not heavy biofilm deposits. The destruction could be commensurate with biofilm, and I don't see heavy destruction with low biofilm. So we need to think that it's probably grade B. Also, now I have, on this patient, I have 3 full mouth sets of radiographs that are 5 years apart. I've been treating this patient for 10 years. So we have the privilege of looking at 2010 radiographs. We have the other privilege of looking at 2015 radiographs. And we have one more set from 2019. Now, what I did is I lined the bite wings up from 2010, 5 years later to 2015, 5 years later, about 5 years later to 2019. And here's what I wanted to show. Could I show direct evidence of bone loss? And I wanted to nail home a couple concepts about using radiographs to try to determine the progression of periodontal disease. And you'll see it here. I'll leave the radiographs on the screen for a little bit of time while I'm making this explanation. But I would tell you, looking at these radiographs 5 years apart, I'm very hard pressed to prove conclusively that there's increased bone loss over the 5 years. I think radiographs are very hard to use unless the disease is aggressive. I think radiographs are very difficult to use to determine the progression of this disease. And that's why I'm a big, strong supporter of using our periodontal charting data, our recession numbers and use that information to help us determine if the bone is, if the patient's losing bone or not, especially on these earlier and these more stable cases that are that we're managing in practice over a long period of time. Now, how about his clinical presentation 10 years apart? On the screen in the top row is to 2010, and this is 2019 in the bottom row. And here's what I would say. If you look at the first molar, upper right first molar, you'll see a significant difference in the gingival height here. This patient also had almost no restorative dentistry in this time. So when I look at the lower right first molar, we see a big change in the amount of root structure showing from the 2010 picture. And then what about the premolars? We see more root structure. These are the same crowns that were on back then. When we go to the left side, we see the same thing. Look at the difference of the clinical attachment loss or the recession. I don't think this patient brushed that away, and I don't think these teeth are outside the bony housing. This is periodontal disease. So this patient clearly, look at the upper left first molar. This patient clearly has some increased recession and increased clinical attachment loss over these years, but I couldn't see it on the radiographs. It was very hard to tell on the radiographs. So well, here's what I have clinical evidence to suggest. I have direct clinical evidence that suggests there's been some clinical attachment loss over the past 10 years. So I know there's been attachment loss, so he's not going to get grade A because grade A is zero bone loss on sequential radiographs. And I would have to tie the clinical pictures with that as well. So the radiographs do not show significant bone loss. So this is a little bit of a conundrum for us, and this is why we have to look at more than just one piece of data to make a determination. So how about the other grade modifiers that would alter the response to therapy and could have an impact on systemic health? Those would be things like smoking and diabetes. So let's see what the health history shows us about this particular case. Well, he was or as far as diabetes, or as far as smoking, he smoked 30 years ago. I got clarification from that, but he doesn't smoke now. So that doesn't advance the grade for us. And his HbA1c I took in the office. I use HbA1c now to take the HbA1c number in the office, and it was 5.3. We also know from our work with our physicians, and we'll probably have more on this at our rally or at our Wellness Dentistry Network rally in May, and we'll have more on this coming up in other webinars, but we have physicians that strongly believe the A1C is not a good predictor for diabetes, so we would use other things like 2-hour glucose tolerance testing and other testing that we can order as dentists, and so we would want to look at that. However, his A1C is 5.3. So on the grading, we still have strong support for grade B, but we do not have evidence that pushes us to grade A or pushes us to grade C. So he is clearly graded grade B. So I also have something interesting on Michael. I have 10-year periodontal charting data, and I have the results of a targeted biofilm metric. So this was 2010, or actually 2009, his first microbial presentation, and it was at disease discovery when he had 48 sites of bleeding. We did salivary bacterial testing back then. And what happened was he didn't respond to localized scaling root planing, so we put him through total mouth disinfection. It took him about 8 months to get stable, which, the average in my practice is about 4.5 months. And at disease stability at a very nice microbial fingerprint that was changed or altered from the original disease presentation, as you can see on the left. And this is nice. Now, what I didn't do for Michael is I didn't take yearly, like I have on other patients, I didn't take yearly bacteria reports, but I collected it again 10 years out, and he still has a different microbial load, even though there's a little bit of creep. he has a different microbial load than he did at disease presentation. The threshold values are a little different now because we've learned more about the disease, but look what else I'm able to have. I looked at every periodontal chart that was taken since 2009 all the way up to 2019, and I looked at the number of bleeding on probing sites. He went from 48 that in the disease state, 48 and 28 until he got stable. Took him about almost 8 months to get stable. And then we started to have some spotty zeros, but the maximum was only 4 sites of bleeding on probing in that, or 5, in that entire 10-year history. This gentleman was very stable and he maintained periodontal stability over the years. And it's great to have this data to show that. And in spite of our best efforts in periodontal maintenance, he still broke down, but he broke down very slowly. So we're very happy with how he's been managed. And we definitely reduced his exposure to, and he reduced his exposure to high-risk pathogens. And we've managed that risk and that exposure now for 10 years. This is our second 10-year documented case that we have where we have similar metrics to show the stability. So here's some questions about Michael's case. What is his disease? Michael's disease stage is, we had some, I'll let you think about it for a second, but the best representation is it's not generalized stage 3 because we had only some localized stage 3 indicators. It's not a molar incisor pattern. There's not less than 30% teeth involved. So what fits the best is localized stage 3, generalized stage 2, and we would add the word active to that at the disease presentation time, and now we would say stable as he has 0 bleeding on probing. Michael's periodontal chart suggested disease is what? The 2009 periodontal chart. Is it active and we only treat it localized? Is it stable and it can be monitored? Is it active and a water pick would be recommended? Could he treat this with just a water pick? Or is this active when we looked at his chart? Is it active and does it require comprehensive treatment and long-term management? And it does, and it did, and we provided that for him. What management strategy would we use? What stage would we base that on? Would we base it on his localized stage or his generalized stage? We always do treatment based on the most advanced stage in the disease descriptor. Always. So even if you have localized stage 3, we're going to use stage 3 treatment protocol. It's going to be a little more aggressive maybe than stage 2. You might do some other things, host modulation therapy or some other things. Also, considering question 4, considering disease severity, what condition would be necessary to advance this to class 4? Well, what we have to have, it has to get very advanced. More probing depths over 6 isn't going to do it because it's 6 or greater. The mobility beyond 2 millimeters may or may not do that, but here's what would do it. What would do it are more than 4 missing teeth. He starts having tooth loss, then that would advance this to class 4. Also, Michael didn't know his A1C or his CRP levels. So if we don't know this on somebody, what grade are we going to assume? Remember, we always assume grade B. We always assume grade B unless we can prove otherwise. So grade number C is the best answer. And then based on these 3 sets, this 10 years of full mouth radiographs and the clinical presentation photos, what is true? Is it true that grade B is appropriate considering the bone loss and clinical presentation? We know that's pretty true. Is it grade A because we have direct evidence? No, the photos, the clinical photos don't support that. However, the bone loss on the radiographs does support. You could argue it could be grade A, but not the photos. Could it be grade C? No, we don't have extensive bone loss on this case. And if he just smoked a few cigarettes, that would not move him to grade C. He'd have to smoke 20 or 10 or more cigarettes. That would move him to grade C. So grade B is appropriate considering the bone loss and the clinical presentation. Let's look at our second case. This is a very interesting case. And again, we're going to move through this a little quicker now because this should start to get a little bit more familiar. So again, we asked the same questions about radiographic interpretation. And as we look at the radiographs on this case, and we're going to look for we're looking for disease severity. Let's look at the radiographs. A close-up of the radiographs show extensive bone loss, 100% bone loss in both periodontal and periapical infections. And as a matter of fact, you can see this is very aggressive disease. These teeth in the front, these front 4 teeth have 100% bone loss, and there's significant bone loss on the rest of the radiographs. And this is a very recent case, and some of you might have seen me present this case in other venues, but there's some really interesting stuff about this case, and this is one that we highlighted on our last month's webinar briefly to look at complexity of disease. And so you can see the radiograph, you can see the extensive bone loss. This is looking pretty severe. You can see there's a suggestion, there's furcation involvement on the radiographs, quite a few things that fit our chart. So the interpretation is 100% bone loss, 50% generalized bone loss. We have some localized areas that are 100%. There are some vertical bony defects. There's some class 2 and 3 furcations. There's periapical lesions. There's some caries around some composites, at least it looks that way. So this case is very complex, and this case is very severe. So here's our radiographic summary to determine severity. And again, based on this data, which stage best fits the disease, and what we're going to have here is we're going to have, looking at the staging, we know there's more than 5 millimeters of clinical attachment loss. We know that there's a bunch of bone loss on the rest of the mouth. We know that this patient's going to lose more than 5 teeth, and this patient needs to be rehabilitated. So this is going to be a stage 4 for sure, and we know that. And now let's look at our periodontal charting to look at complexity. And you can see on the periodontal charting, there's very active disease, and we have pocket depths 2 to 10 millimeters, lots of recession, lots of clinical attachment loss, complete 100% clinical attachment loss on some teeth, 16 millimeters, class 2 and 3 furcations, 74 sites of line bleeding on probing, 5 hopeless teeth. This is a very severe disease chart. So based on the periodontal charting data, and in addition to the radiographic data, the complexity just gets worse, and it doesn't change the staging in any way. This is clearly going to be stage 4. Looking at the clinical presentation, we do have some flaring teeth. We have some drifting teeth. We know that some of the teeth are helpless. It also looks like there was a decent amount of biofilm on the teeth, but I wouldn't call it heavy. I actually would not call this heavy biofilm, but it's extensive clinical attachment loss. So we want to look at the biofilm, and it's really not that heavy, although the gum tissue does look oddly suspicious. And I'll talk a little bit about what that is in a minute. So based on the clinical presentation data, in addition to the periodontal and radiographic data, is the complexity change or advance the stage? It's still stage 4, and grade, it's going to be grade C, because the destruction here definitely exceeds the expectations given the biofilm deposits. I just didn't see much biofilm. And I have a little bit more information about that as we go forward. Looking at the additional things that would advance the grade for this case, it would be the HbA1c. I tested it in the office. It was only 5.2. And this patient also smoked, but quit 40 years ago. So based on the medical history, this grade is still, the medical history would leave a grade B, but we have a more advanced grading based on the disease complexity and the low, maybe biofilm load, but the severe extent of the damage to the teeth. And so that's what we're going to use for grading. Now, interestingly, in this case, we know we have a very active disease, but look at the pathogen load. Even the pathogen load is not that dynamic. I mean, I would expect to have a lot more bacteria. So when you get this, and you get this data, and you see that this is there's a disconnect between the bacterial levels and the potential potential disease. Start asking some questions. And the question that we asked in this particular case is, look, there's two main things that determine this disease. It's going to be the pathogen profile, how bad are the pathogens, and then what modifies the risk. Well, she doesn't smoke. She doesn't have diabetes. So maybe I don't know all that I need to know about the pathogen profile. So one of the things we did in this case is we dug deeper and we measured for yeast. And that's what that funny tissue look was. That reminded me that this patient might have a yeast component. And in fact, she has Candida lusitaniae. And Candida lusitaniae is a very aggressive, rare, uncommon yeast pathogen. And some of these are resistant to antibiotics. And you know that yeast doesn't respond to antibiotics. So this patient has a yeast component to this disease. What else do we know from our studies about viruses in severe periodontitis? There's a couple things that I would add about viruses. I couldn't test and didn't test her for viruses. However, from our literature, we know in Dr. Slotz's papers about viruses that when you have severe periodontitis, you're going to have herpes viruses, sometimes more than one. And herpes virus can be the major pathogenic determinant. We also know that the therapy that targets herpes viruses and bacterial pathogens can help. And what do we know that we have to do that? Well, it's going to come up in the next slide. And what Dr. Slotz is reminding us that these herpes viruses are probably one of the things that we should look at that could enter the systemic circulation and hopefully, and potentially, not hopefully, but potentially infect a large number of organ systems, that we have a bigger risk from viruses than maybe we even do from bacteria. Again, he reminds us that these lesions frequently are infected by 2 or more herpes viruses. And again, we have inexpensive antimicrobial periodontal options that we could use. We have antibiotic, we could use antivirals, and we could use antibiotics, either rinse or systemic antibiotics. And what else could we use? Very strong antiseptics. And what are we going to use here? Either iodine or sodium hypochlorite. We prefer the sodium hypochlorite. That works really well. And I've included the recipe here in the event that you want your patients to make this at home. I don't do that. I use only carie-free CTX4 treatment rinse in all of the periodontal therapy as a base. And once if we don't get successful with that, then we build on that with something else. So in our grading, we take into account the biofilm, what the biofilm load is, and the commensurate destruction based on biofilm. And we started to learn a lot more in this case because it wasn't just bacterial. We know there's a viral component and a yeast component as well to this case. So in our grading, this is clearly grade C, and that's how we would grade that. So Mary's disease, this is a little bit easier now. Mary's disease is clearly, it's generalized. This is not just localized, it's generalized. We also know that Mary's chart suggests with 78 spots of bleeding and all the destruction, we know that she needs comprehensive treatment. We know you're not going to help her with a water pick, or this surely can't be monitored. This patient needs aggressive treatment. And what stage best describes it? It's clearly just generalized stage 4, very advanced disease. And again, this is an interesting concept. Question 4. Let's spend a couple minutes on this. Considering that the hopeless teeth will be removed, so you're going to basically get rid of the worst offenders, and no other teeth have bone loss beyond the middle of the root, 50%. Could you downgrade this classification to stage 3? And the answer is clearly not yes. You cannot downgrade to stage 3. You have to take into account what this was like. So I ask all my patients, how did you lose your teeth? How did you lose your teeth? And if they say it's a periodontal disease, it's going to be stage 4 if it's more than 4 teeth. And it's not going to be able to go back to stage 3. And remember, this is a risk for future implant placement as well. So we have to think about that as well. And again, because what level of destruction does she have? She has, the destruction is not commensurate with the biofilm that we could see. I mean, she wasn't a bad brusher, but when we start to do metrics, we start to learn she has a very aggressive yeast and she has viruses. We can assume she has viruses. And so this is going to be grade C because she has a significant amount of destruction and it's not really commensurate with what's visual. And that's the beauty. That's what the beauty of what we've learned looking at biofilm metrics over the 10 years that we've been doing this, is that many of these cases surprise us, and we need other clinical data to determine what the real etiology of the infection is. So again, these components of the comprehensive evaluation are critical, and we cover these in other webinars in detail. We're going to continue to pick apart nuances of these. But I'm really excited because this staging and grading has really forced us to update our risk modifier form. Next month, I'm going to really go through the new modifier form line by line and talk about how these different things affect the disease. And you have the updated modifier form in the library right now currently for you to review and for you to start taking and capturing this data on our patients. And we do this, we collect the risk modifier data on every single patient that we do salivary diagnostics on, so that we have that data as we're considering how to treat the disease. So I want to now move to, we looked at staging and grading. We looked at a couple cases that have interest, that have good long-term data. The first case has great long-term data. Second case is a very interesting twist. And now I want to talk about how you say it is so important and how staging and grading helps us to simplify the language. We know, and we've described it beautifully, that you use probing depths, recession, bone loss, furcation. You always include the terms generalized or localized, active or stable. This is how our hygiene team can talk to us and our periodontal therapists. And remember, when you have this mixed case type situations, always state the most severe case type first, because that's going to dictate treatment, and the less severe case type second. And it simplifies our language. And here's what I mean by that. And also print your staging and grading sheets out, have them in the office, show patients what they are, let them know what stage they are, and start to educate your patients. It'll make a big difference in how they view the disease. So how this helps in our communication is when I walk into the hygiene room or the therapy room and one of our hygienists says generalized stage 2, I already know the pocket depths. we know there's no pocket depths greater than 5. I already know the clinical attachment loss. And when they say grade B, I know that we have no direct proof to prove otherwise than grade B. And when they say active, I have one simple response. By the way, I don't need anything more in the notes than that. I don't need to know what the tissue looked like. I don't need to know that the tissue was boggy or spongy or erythematous. I just need to know these words. And once I know that, my response is really simple. What's our plan? What's our plan for the patient? How are we educating the patient? What are we going to do for them? And what are we going to suggest that they do for themselves to help them get rid of the disease activity? Because I don't know how, depending upon how active it is, we may have to do a lot for the patient or we could do a little. But this is how this really helps communication. We don't have long discussions. It's very quick. And what if this description was a little bit different? What if it was generalized stage 2, grade B, stable? Now I get to say one other thing to the patient. I get to say, Joe, what do you do in between your teeth? He says, I floss. I'm going to say, congratulations, it's working. Our hygiene team today determined your disease is stable. That's beautiful. Keep up the good work. Also, what do you get to, what else you get to do? You get to congratulate the patient, but you get to do one more thing too. You get to tell them what diseases and what some of the implications they might be avoiding by doing such a good job. So you get a chance to really share with the patient how you're working and what you're doing. And we outlined this communication tip in an earlier webinar. How about moving beyond the mouth? Does staging and grading move us closer to understanding the systemic impact? Absolutely it does. Absolutely it does. And we know now that periodontal disease is linked to 57 other referenced diseases. So we know there's extensive amount of research going on in this disease, and we know this has grown. So what do we want to do? We want to move even beyond smoking, and we want to move beyond just diabetes, and we want to start collecting other biomarker data. So what staging and grading does is it classifies these patients by these two dimensions beyond just severity. A couple dimensions, because what are the other dimensions? Response to therapy, pace of bone loss, and it really helps us to see how they're going to respond, and it gives us more information than just simple disease severity, which is what we used to have. And then there's the risk stratification is going to get stronger and stronger. We know that smoking is well validated. Type 2 diabetes is well validated, especially if it's uncontrolled, that it makes a big difference. And we have lots of clinical evidence also clinical evidence of disease progression at an early age can make a big difference. And severity of bone loss relative to the patient's age is taken into account when we use these charts. And what does the summary of this paper talk about? It talks about how the new staging and grading explicitly acknowledges the potential for some of these cases of periodontitis to influence systemic disease. So this is a great new horizon for us, and we want to start working with this in the practice. And some of you may have seen this case from me in other venues as well, but this is a patient that clearly has periodontal disease and caries, and some significant breakdown and loss of posterior teeth. And you can see periapical and periodontal infections on the Panorex. Why I'm showing you this is because this periodontal charting is an example of very aggressive or very active disease. This patient needs treatment. And so what do we want to do before we treat these types of patients? It would be great to run an inflammatory biomarker panel. And we know as Wellness Dentistry Network members, you can do this. You can run these biomarker panels, and we can start to learn about some of the biomarkers that these patients have that could have other broad range systemic influence. And we get to learn one more thing, what our treatment does to help us see change in these biomarkers and to start to establish that dentists can make a difference. So on our test, we have some biomarkers that look at inflammation. We have other biomarkers that look at lipids. We have other biomarkers that look at metabolics. And we have a couple biomarkers that help us with nutrients. And when we have an infection, generalized stage 4, grade C, active infections, when we have other descriptors that describe diseases, and we look at pre-treatment metrics, and we look at 1 month post-op and 3 months post-op and some other time post-operatively, we need to collect, and I need you to help me as Wellness Dentistry Network member offices. I need you to help me collect this data so we can start to prove and make a difference that as we monitor these objective biomarkers of systemic health, it'll further validate the effect of periodontal disease on systemic health and vice versa. So it's really a great opportunity for us in dentistry, and I hope you'll help me get there. That would be great. Also, I want to remind you, in the library, I have a very extensive 70-page, you can use it electronically, staging and grading team exercise. You can use this exercise to educate your teams. You can have your teams watch this video, which is housed in the library. But this staging and grading team exercise is just another piece. And where I put it in the library is if you expand the menu under gum disease in your Office and Forms Tools library, you'll see under 2C diagnosis, the staging and grading exercise, and is right next to your charts, right next to our staging and grading charts. These are our printable reference charts. And here's the exercise. And I also made a 59-minute video that explains this page by page. So you have yet another explanation for your team, and it's narrated. You could have your team watch it when you're out of the office, watch it for an office meeting, and it's a video explaining more of these same concepts, just yet another way. I also wanted you to know in the video section, I've also stored the staging and grading exercise video there as well. So you can find it in two places. You can find it related to the staging and grading reference charts, and you can, into the team exercise, and you can find it in the video library. There's also a 5-minute video about the workshop that happened, the joint workshop between the American Academy of Periodontology and the European Federation. Just a small little clip in the video section. Now this is in the video section of the, so you'd go to the dashboard, you'd go to videos and the recorded webinars, and under the videos, when you do the drop-down menu, you'd go to gum disease, and that's where this video is housed. So our next webinar is going to be November 4th. Again, forward comments. I'm not going to have any interactive question and answering from this webinar today, but I would like to offer you the opportunity to email us questions. I hope I've created multiple resources for you to learn this and for you to share this with your team. Remember, save the date, May 15th and 16th in Detroit. We're shaping up our member rally. We'd love for you to come with your teams. We have room for 150 people. It would be great to have you there. We'll have some physicians, and we'll have the agenda for that is forthcoming. Let us know what you'd like to learn or hear about. But we have lots of opportunity, and our library has gotten really quite robust over the last year. So come and help us. And we will have and make the rally open to a couple of non-members. So if you have interest in doing that, let us know. And then the AOSH meeting, the American Academy of Oral Systemic Health, is just coming up next week. And this is the 17th through the 19th in Nashville. We will be there. We'll have a vendor booth. So if you're there, stop by. I think it's booth 111. Stop by and see us, chat with us, and let us know what we can do to help you grow more in the future. So again, 3 critical points about why this process, the wellness process, is successful. You've heard me say this before. It is unique, it is relevant, and it is true. It doesn't fit in every practice, but it fits for every patient. It just happens to be we have to figure out how to deliver that information. So I want to thank all of you for your efforts to bring these health opportunities to your patients and to your families. We know that most of this has started with you and your family. I have one other announcement that I needed to make as well. I should have been back on the prior slide, and that is we are bringing hygiene courses to the Coy Center in Seattle, Washington. So you could go to www.coycenter.com. You could look for the hygiene courses, but many of us have made requests, many of you have made requests to get hygienists trained at a higher level. And we can do that in a 2-day course at the center, and it'll include a lot of workshop materials like we went over here today. Remember, a healthy man has a million wishes, right? When we're healthy, we want all kinds of things. When we're sick, we just want one thing. So I want you to give your patients and have your patients to keep having a million wishes. Thank you again so much for your attention and for sitting in on the webinar. And until next time.